Welcome to the deep dive. Today we're taking a set of notes on a specific medical topic and doing what we do best, diving deep to pull out the essential information tailored just for you.
hmm
Think of this as your high-yield guided tour through the critical points of a single condition, perfect for, solidifying your understanding or quickly getting up to speed.
Sounds good.
We've got a detailed set of revision notes in front of us, all focused on thyroid cancer. Our mission is to unpack these, zero in on the most important knowledge nuggets, and make sure you finish this deep dive feeling well-informed and ready to tackle this complex area.
That's right. We're going to break down exactly what thyroid cancer is, explore the factors that increase risk, understand how it behaves, and how it typically presents.
Right.
Crucially, we'll cover the investigations needed for diagnosis and the key principles of management. We'll also touch on the prognosis and potential complications. The goal is to highlight the absolute must-know facts and connections laid out in these notes.
All right, let's unpack this, starting with the fundamental question. What exactly is thyroid cancer?
Okay, so at its core, it's the malignant growth of cells within the thyroid gland. You know, that small butterfly-shaped gland in your neck.
Yeah, the one making thyroid hormones.
Exactly. Responsible for producing vital thyroid hormones. What's really important to grasp from the outset is that it's not just one single disease. The notes make it clear there are several distinct subtypes, and knowing which one you're dealing with changes, well, everything.
Okay, so the subtypes are crucial. What are the main ones described in these notes?
The most common group falls under differentiated thyroid carcinoma. This includes papillary thyroid carcinoma, PTC, which these notes tell us is the most frequent type, tends to grow slowly, and generally has a very good prognosis.
Okay, PTC, slow, good outlook. Got it.
Then there's follicular thyroid carcinoma, FTC, the second most common. This one behaves a bit differently. It has a tendency to spread via the bloodstream, hematogenously, often to the lungs and bones.
Ah, so different spread pattern.
Yes, and within this differentiated group, there's also Hurley cell carcinoma. The notes highlight this as a more aggressive variant with a lower survival rate compared to the other differentiated types.
Hurley cell.
More aggressive.
That's
Okay.
right. Beyond the differentiated types, we have medullary thyroid carcinoma, MTC. This is distinct because it arises from the parafollicular C cells, not the follicular cells like papillary or follicular.
C cells, right, different origin.
Exactly. A key point here, according to the notes, is that MTC can be hereditary, and elevated calcitonin levels are a crucial indicator for its presence. That's a big diagnostic clue.
Calcitonin for MTC, important marker.
Definitely. Then there's the very aggressive anaplastic thyroid carcinoma, ATC. These notes describe it as rare, highly aggressive, with a poor prognosis, typically affecting older individuals.
Anaplastic, rare, aggressive, poor prognosis. Not good.
No, not at all. Finally, they mentioned thyroid lymphomas. These are essentially non-Hodgkin's lymphomas that occur in the thyroid. Often seen in areas with pre-existing thyroiditis, commonly affecting older females, often around age 65. Wow, that's quite the lineup. So we've got the differentiated types, papillary, follicular, Hurley, then medullary from C cells, the really aggressive anaplastic, and lymphomas. It really underscores your point. The type is the primary determinant of how it behaves and how it's treated.
Absolutely. And to assess how far the cancer has spread, these notes reference the standard TNM classification system, TNM.
Right. Tumor, nodes, metastasis, standard staging.
Exactly. This system stages the cancer from stage I, localized, up to stage 4, metastatic. It uses T for tumor size, N for lymph node involvement, and M for distant metastasis. A key detail highlighted in the notes is that even small tumors are considered stage 2 if there's distant metastasis, regardless of lymph node involvement.
Oh, interesting. So M1 automatically bumps it up, even with a small t and no N.
That's what the notes imply for how stage 2 is defined in some contexts here, emphasizing the significance of metastasis. So understanding the stage, along with the type, is foundational for planning management.
Makes sense. Okay, so we know what it is, and it's different personalities, it's types. But why does someone get thyroid cancer? The notes are pretty direct on this initially, saying the fundamental cause is unknown. Is that the whole story, or do they give us clues?
Well, the ultimate trigger is often unclear, that's true. But these notes provide a very strong list of factors that significantly increase the risk. And this is really high-yield information you need to lock down.
Okay, what are the big ones? What jumped out from the notes?
The most significant risk factor highlighted is ionizing radiation exposure, particularly exposure during childhood or adolescence.
Right.
This includes previous therapeutic radiation to the head or neck area. The notes specifically mention real-world impacts, like the increased risk seen years after events like the Chernobyl disaster, especially in children exposed. That connection makes the risk factor much more memorable, I think.
That's a powerful, tangible example, definitely. What else makes the list?
Family history is also crucial. That means a history of thyroid cancer itself in the family, or a history of certain related hereditary syndromes.
Like MN2.
Exactly, like multiple endocrine neoplasia type 2, which involves tumors in multiple endocrine glands, or familial adenomatous polyposis, FAP.
So genetic predisposition is definitely in play.
It is. The notes also mention specific genetic mutations like RET or BRA as risk factors.
Okay.
Beyond genetics and radiation, other factors listed include a history of a simple goiter, pre-existing thyroid nodules, or thyroiditis inflammation of the thyroid.
So previous thyroid issues can be a risk.
Seems so. Demographic factors are also noted. Being female significantly increases risk compared to males.
Why is that, do we know?
The notes don't really delve into the why there, just state the association. Also, being of Asian or Black ethnic groups, based on the UK data presented, shows higher incidence compared to whites. And obesity is also listed as a risk factor.
That's a comprehensive picture of the risk landscape. For anyone preparing for exams, running through hypothetical patient scenarios with these risk factors would be a great way to cement this knowledge, wouldn't it?
Absolutely. Good strategy. Now, moving on, the notes briefly touch on the pathophysiology, essentially, how the cancer develops at the cellular level.
Right.
It really boils down to uncontrolled cell growth, driven by, genetic mutations. The specific mutations and the type of thyroid cell affected determine which subtype of cancer develops and therefore how it behaves.
So the specific molecular screw-up dictates the type.
Pretty much. While this section in the notes is concise, understanding that underlying cellular dysregulation is key context.
It's that fundamental concept of malignancy. And these notes also provide some fascinating statistics on how common it is, the epidemiology.
Yes, this section is quite interesting. It states that globally, thyroid cancer is relatively rare. But here in the UK, the incidence is actually increasing.
Increasing by how much? The numbers in the notes were quite striking.
They are. It currently ranks around 20th among all cancers in the UK, with about 3,000 new cases diagnosed each year. But the incidence has risen dramatically, a 175% increase since the early 1990s.
Wow, 175%.
Yeah. And it's projected to increase by another 74% by 2035. That statistic alone really jumps out and raises an important question. Is this purely due to better detection methods, maybe more imaging? Or are there other factors at play? Environmental, lifestyle.
That scale of increase is certainly thought-provoking. Better detection must be part of it, but
It's a big jump. The notes also mention it's the most common endocrine malignancy in the UK and confirm that papillary carcinoma is leading this rise in incidence.
papillary driving the increase.
Seems like it. They also point out higher incidence rates in Asian and Black ethnic groups compared to whites in the UK based on 2013-2017 data.
Interesting demographic points there, too.
It definitely highlights that even for a relatively rare cancer, its footprint is changing, which is something to keep in mind.
Okay, so shifting gears now to how someone with thyroid cancer might actually present to a doctor. What are the typical signs and symptoms described in these notes? What should you look out for?
The most common presentation by far is the presence of a thyroid nodule or swelling in the neck. Just finding a lump.
A lump. Okay. Painful. Painless.
Often painless, actually. But you need to look for other signs that might suggest something more concerning. The notes list changes in voice quality or hoarseness.
Right.
They specifically mention vocal cord paralysis here, which suggests involvement of the recurrent laryngeal nerve. That nerve runs very close to the thyroid gland, you see.
Okay, so voice change is a red flag for nerve involvement.
It can be. Difficulty swallowing, dysphagia, or breathing, dyspnoea, and enlarged neck lymph nodes are also important indicators mentioned.
And the physical characteristics of the nodule itself can be telling, right? The notes describe worrying features.
Exactly. Like a nodule that feels hard, is fixed, stuck to surrounding tissues, or is rapidly growing. Those are concerning signs on examination.
Hard, fixed, growing fast. Got it. What about thyroid function? Hyper or hypo?
Occasionally, patients might have symptoms of hyper or hypothyroidism, but the notes suggest this isn't the norm. Usually, thyroid function tests are normal. But those physical clues are critical, and the notes provide a really useful list of red flag signs and history points that should immediately raise suspicion for thyroid cancer and warrant urgent investigation. These are high-yield points for recalling who needs a closer look.
Let's go through those red flags. Definitely need to know these.
Okay, the key red flags listed are A family history of thyroid cancer. Any history of significant radiation exposure to the head or neck. Finding a thyroid nodule in a child. Any thyroid nodule in a child is suspicious and proven otherwise.
Right. Nodule in a child equals red flag.
Definitely. Unexplained hoarseness or stridor, that high-pitched, noisy breathing sound occurring alongside a goiter, a thyroid mass that is rapidly enlarging, even if it's painless.
Rapid growth. Okay.
Palpable, hard cervical lymph nodes in the neck. And finally, thyroid or neck pain that is insidious, meaning it develops slowly or persistent, lasting for weeks.
That's a really clear, actionable list of warning signs. Remembering these red flags seems absolutely vital for clinical practice and revision. They tell you who you need to worry about and refer promptly, probably on that 2-week wait pathway.
Precisely. That leads us nicely into how these cases are investigated. The notes mention that 2-week wait referral for unexplained thyroid lumps.
Okay, so if someone comes in with these signs or risk factors, how do doctors figure out if it's cancer, according to these notes? What's the typical investigation pathway?
The notes outline a standard approach. It starts, naturally, with a thorough physical examination of the neck, palpating the thyroid, feeling for nodules, checking lymph nodes.
Makes sense.
Thyroid function tests are usually done, although, as we mentioned, patients may not have abnormal hormone levels. They're often euthyroid.
Okay, check TFTs anyway, then imaging.
Yes, imaging is a crucial next step, and ultrasound is the first line. It's great for looking at the thyroid itself.
What are they looking for on ultrasound?
Assessing the characteristics of any nodules, found things like size, shape, margins, calcifications, blood flow, and checking for suspicious lymph nodes in the neck.
Got it. Ultrasound first. What if they need more?
If there's concern about spread beyond the neck, or maybe planning surgery, CT or MRI scans might be used later.
Okay, but how do you get the actual diagnosis?
The definitive step for diagnosis is the fine needle aspiration FNA biopsy. This is where a small, thin needle is used, often under ultrasound guidance, to take cells directly from the nodule.
FNA biopsy, key step.
Absolutely key. These cells are examined under a microscope by a pathologist. The notes emphasize that FNA is vital to distinguishing between benign and malignant nodules.
And you mentioned something specific for MTC.
Yes, for a suspected medullary thyroid cancer, specifically a serum calcitonin blood test is highlighted as an important diagnostic tool. Remember, it comes from the C cells.
Right, calcitonin for MTC. Makes sense. So physical exam, LEDs, including TFTs, and maybe calcitonin ultrasound first, then maybe CT MRI. But FNA biopsy is absolutely vital for getting cells.
That sums it up well. And the notes also add a useful caution that radionuclide imaging, like iodine uptake scans, hot or cold nodules, is generally not reliable or recommended for the routine diagnosis of thyroid cancer itself, although it has roles later in management sometimes.
Good point. FNA is the diagnostic workhorse for the nodule itself.
Exactly.
Okay, so once a diagnosis is confirmed, what are the main ways thyroid cancer is managed? Based on the information here, what happens next?
The notes strongly emphasize that management is highly individualized. It depends heavily on the specific cancer subtype we talked about, its stage, TNM, and of course the patient's overall health and wishes.
Tailored approach.
Very much so. This requires a multidisciplinary team approach. Surgeons, endocrinologists, oncologists, radiologists, pathologists, specialist nurses, all working together.
Makes sense for complex cases. What are the primary tools in the toolkit for treating it? What options are listed?
The notes list several core treatment modalities. Surgery, usually a thyroidectomy removing part or all of the thyroid gland, is often the initial and primary treatment, especially for differentiated cancers.
Surgery first, often.
Often, yes. Then, radioactive iodine therapy, RAI. This is clever. Thyroid cells naturally take up iodine, so you give radioactive iodine, which gets taken up by any remaining thyroid tissue or differentiated cancer cells elsewhere in the body and destroys them. It's used after surgery.
Ah, targeted radiation from the inside.
Sort of, yeah, for differentiated cancers. Then there's external beam radiation therapy, EBRT, which is radiation from a machine outside the body. That could be used in certain situations too.
Okay, RAI and EBRT. What else?
Targeted therapy, using drugs that focus on specific molecular pathways in cancer cells, is mentioned, particularly for more advanced cases that might not respond to RAI, or for types like MTC or ATC.
Newer drug approaches.
Yes. And of course, after a total thyroidectomy, the patient no longer produces thyroid hormone. So thyroid hormone replacement therapy, usually levothyroxine, is necessary lifelong. This also helps suppress TSH, which can potentially stimulate growth of some thyroid cancer cells.
Right, lifelong hormone replacement. crucial. And what about the specific approaches for those less common but more aggressive types like medullary or anaplastic? Did the notes detail that?
They did. For medullary thyroid cancer, complete surgical resection is the goal for disease confined to the neck area. For recurrent or metastatic MTC, management can involve more surgery, external beam radiation, and systemic treatments like targeted therapies. Kinase inhibitors are often used.
So surgery is still key, but targeted therapy is important for advanced MTC.
Correct. For the aggressive anaplastic thyroid carcinoma, the management is often complex and, sadly, often palliative. It depends heavily on the stage and patient fitness wishes. The notes mention a multimodal approach, potentially excisional surgery if possible, which is rare, external beam radiation, chemotherapy, targeted therapy if specific mutations like BRAF are found, and even immune checkpoint inhibitors.
A real kitchen sink approach for ATC, sounds like.
Trying everything possible, often with palliative intent given the poor prognosis. So that gives a clear picture of the varied treatment strategies depending on the cancer's specific identity. The notes also make it clear that regular follow-up is critical after treatment.
Follow-up. What does that involve?
Checking for recurrence. This includes blood tests to measure markers like thyroglobulin, TG, and thyroglobulin antibodies, PGAB, for differentiated cancers, as well as calcitonin for MTC, and regular neck ultrasound scans.
Okay, long-term surveillance is key. Let's turn now to the outlook, the prognosis. The notes start the section with a generally positive message, didn't they?
They did.
Right, it says generally favorable with high survival rates. That's encouraging, isn't it?
It is, especially for the most common differentiated types, papillary and follicular. The notes state that overall there's a very good prognosis with a high 5-year survival rate, often quoted as up to 95%.
95% 5-year survival. That's excellent news for many patients. But that prognosis isn't the same for every type, is it? You hinted at this earlier.
Absolutely not. These notes highlight the stark contrast. While papillary and follicular carcinomas have the better outlook, the prognosis for the anaplastic type is significantly poorer. The notes give a 5-year survival rate for ATC of just 5%.
5%. Wow, that's grim. It dramatically illustrates why the subtype classification we discussed early on is so critical.
It really does. Prognosis varies hugely.
Were there other factors mentioned that affect prognosis besides type and stage?
Yes, the notes provide interesting details on demographics. Females generally have higher survival rates than males.
Any idea why? Hormones?
Again, the notes don't specify the mechanism, just the observation. And prognosis is best in younger adults, specifically those under 50 years old. Age is a significant prognostic factor.
Younger age, better prognosis.
And, naturally, early-stage diagnosis also significantly improves survival rates, which makes sense catching it before it spread widely.
Right. So while generally good news for the common types, especially caught early in younger individuals, the picture changes significantly for the more aggressive subtypes and sometimes with age or sex. What about complications? What can go wrong, either from the cancer itself spreading or from the treatments?
The notes list several potential issues. These include, obviously, the cancer recurring locally in the neck or spreading metastasizing to distant organs or lymph nodes.
Recurrence or metastasis.
Yes. After surgery, impaired thyroid function, hypothyroidism, is expected if the whole gland is removed, hence the need for hormone replacement.
Right. Hormone replacement is management, but lack of thyroid function is a consequence.
Exactly. Voice changes, or even permanent hoarseness or voice loss can occur if the recurrent laryngeal nerve, located close to the thyroid, is damaged by the tumor itself or during surgery.
Nerve damage risk.
Yes. Difficulty swallowing, dysphagia, is another possibility, perhaps due to nerve issues or scarring. And, importantly, the emotional and psychological impact of a cancer diagnosis and treatment is also listed as a potential complication or challenge.
That's a really important point, the psychological side. The notes specifically mention that surgical complications like nerve damage are rare when performed by expert surgeons, quoted at less than 1–2%.
That's right. The risk is low in experienced hands. But the notes also highlighted that nerve damage isn't solely a complication of cancer. It can sometimes occur as a risk of the thyroid surgery itself, even for benign conditions, though again, it's rare with experienced surgeons.
Okay, so it's a known, though uncommon, surgical risk, regardless of malignancy.
Correct. The notes finish this section by reiterating the importance of regular follow-up and lifelong thyroid hormone replacement therapy for managing patients long-term after treatment.
Oh, wow, that was a really comprehensive deep dive, pulling out all the key points directly from the notes you shared. We've navigated the landscape of thyroid cancer, covered its definitions and diverse types, the factors that increase risk,
The etiology and risk.
how it presents clinically, the steps for investigation, the tailored management strategies, the typical outlook or prognosis, and potential complications.
Yeah, we've aimed to distill this complex information, emphasizing the high-yield facts and connections presented in the source material, which is exactly what you need whether you're revising or just looking to get a solid grasp on the topic quickly.
Thinking about that statistic, we mentioned the surprising 175% increase in UK incidence since the 90s, and the projection for it to keep climbing it really prompts you to wonder, beyond improved detection, what broader shifts in our environment or lifestyles might be subtly contributing to this trend. It's something to keep in mind as you integrate this knowledge, perhaps.
It's a definite point to ponder. What else could be driving that significant rise? More research needed there, I suspect.
Absolutely. That brings us to the end of this deep dive. We really hope this structured exploration of your notes has been incredibly helpful for your revision or simply expanding your understanding of thyroid cancer.
Learning complex medical information effectively often means breaking it down, understanding the why behind the facts, and seeing how different pieces connect, much like we've tried to do today. Hopefully this format helps with that.
Absolutely. If you're getting ready for exams like the MSRA or similar, actively engaging with your source material like this, pulling out the key bits, maybe making your own notes from discussions like this, is a powerful way to learn. For more resources and practice questions that align with this type of high-yield approach, you might find passthemlsra.com and freemsra.com/helpful. They have specific materials for that exam.
Good resources to check out.
Thanks for joining us for this deep dive. We look forward to helping you unpack your next set of sources soon.